Normally, that everybody, those who are starting from the or graduation time or becoming a physician, doctor, we start our treatment of blood pressure, and lifelong it goes on. But problem is that many times we don't consider another important tool of our hypertension management. One of the important tool is ABPM. Before this lecture I am preparing, before that also I was not so much of what we call insight about the ABPM, that which I got it. So we'll discuss today. So it is a common cardiovascular risk factors and normally treated based on reading obtaining from the clinics or our clinics one, and that is the normal timing of everybody is fixed, that either he will sit in the clinic by morning or in the afternoon or evening. So timing is fixed, and patient comes to us once in a month or twice months basis, and accordingly we fix the exactly how it is the blood pressure and have to titrate the medications. But the problem important is that ABPM and home-based blood pressure monitoring both have the strong association with the cardiovascular risk factors, and we have to keep these important tools to plan the management of hypertension. So normally what we see and how we do this blood pressure, and you know the factors which are affecting, mostly this is a very commonly we discuss every time, but still we should emphasize to location, that also depends on the temperature, humidity, noise, that also gives a lot of difference in the blood pressure monitoring. Observers, normally what happens, if you see the patient is coming to you watching the your measurement of the blood pressure, suddenly some phone rings, that also gives a lot of differences in the either observer or the patient's cough also is there. Blood pressure monitor is also there. A lot of things are automatic, stethoscope, maintenance, everything, all of things. And most important, the subject, anxiety, exercise, tobacco. This all normally we don't ask, don't practice. We know everybody, but we don't practice. And normally, you know, these all the things that BP is getting, how we are making blood pressure, and the normal protocol wise, we should sit for the more than 5 millimeter or 5 minutes or so. After that, we can get it. But normally, after this also, getting the treatment is very difficult, and because of that, because if you are treating a patient continuously for 5 years, after that he has got some retinopathy or some kidney dysfunction, that means there is something problem with us only, we could not manage properly. So at least in ABPM is important tools, when at least 2 measurements per hour should be taken during this ABPM. Normally in this slide I want to say, get very few words like ambulatory blood pressure, home blood pressure, out of the office blood pressure, self-management. These all things are to be considered and to be taken very importantly, seriously. You know, all stages, stage 1, stage 2, I will not go in detail, and severe hypertension. When it started, it is almost in 1960. These are the previous photos I got in the Google. That time that was one automatic inflatable cuff is there. You can see that's hanging this lady, that automatically himself or herself has to inflate the cuff, and then you have to take blood pressure automatically with them. But it is continuously built on the very big. Now changes, you know, is very simple, fully automated, compact, typically worn on the belt on the touch and connected to the spin ventricular cuff on the upper arm by the tubes. And nowadays there is some companies in some new versions of Apple also giving some ideas how to get this blood pressure, heart rate, everything. So these measurement protocols are a minimum 70 to 80% of planned readings are obtained, at least 14 days obtained during the daytime, or at least 10 in daytime or 5 in night times, because many times it happens that patients doesn't feel comfortable that time. So normally what we see, this is the normal protocol or normal images that we can make out of this, and this is a normal blood pressure in ABPM, that all the pressure should be around this gray lines in day and daytime, night time. If you say about, this is a study is reviewed by the United States Preventive Services Task Force. What they have done, they have taken almost 22 studies, And prevalence of hypertension ranges from 5 to 65%. So one of the important factors that we always miss is white coat hypertension, and the ranges, because we don't consider, because normally we are a very busy practitioner, so immediately whatever BP we see, accordingly we create the medication. That is also very wrong, and many a times what we say, what is white coat hypertension, another is white coat effect. The patient, once he got the hypertension in doctor's chamber, but when he goes at home, that time also he feels that he is in anxious anxiety. So their continuously effect will be there after your chamber also. But previously was totally normotensive. So this is another important misnomer that we treat the patients. This is normally grading of how we see different kinds of pressure line in borderline hypertension, moderate to systolic and diastolic hypertension, and severe systolic hypertension. In both the conditions, we should get the proper treatment according to the timing and all the things. So if you're going to see some of the cases that isolated systolic hypertension, how we'll see. So night time, that all the blood pressure monitoring, diastolic pressure is under the control, but in daytime from the night there will no dippers. So that we can understand, and then could treat the patients, especially with the different kinds of we can plan the management of the patients, that how we can good this. Another important pattern is dipping pattern, that there is a normal pattern, you should always be taken care of, because normally all the patients, whenever they are sleeping, and the blood pressure should reduce at least 10% or 10 millimeter of mercury from the day mean. If it is not there, that means it is not dipper. So non-dipper is a very different studies that they have a very great progress in cardiovascular mortality and others. So dipping pattern should be always be kept in mind and to be taken. So some individuals do not experience normal decline in blood pressure at night, and those who blood pressure doesn't decline between the daytime and night time, 10% or more, then ABPM should consider non-dippers and can have more nocturnal hypertension, which commonly defines the mean night temperature more than 120/70. If you get this. So all-cause mortality is associated with this higher. So we can see non-dipper pattern, how we'll see. Patient is having the hypertension or high blood pressure in daytime also, and at the same time, night time there should be a dipper, but that is not also there. So they have a very great prognosis in future for cardiovascular risk and mortality in all parameters. Sometimes we see hypertension also, and that is also postprandial drug-induced hypertension or autonomic dysfunction. Usually, normally many patients comes to us that, sir, BP is very low, so what to do? So we should see exactly the cause of this, whether we are taking some other medications or so. That can be, and many times we have a severe history of syncopal attack that we don't know the reasons. We should see this by ABPM, what is happening inside, just like Holter. So it should be better that we can have this pressure. And this is the normal hypertension. Whenever this should be correlated, suppose somebody is taking some history of hypertension, which can be correlated with this correlation with the symptoms that the patient is having hypertension or some other reasons, maybe some. So one of the important factors now that we always miss, we see that white coat hypertension we talk more, but mask hypertension is another important that when we should consider. In a study in Europe and Japan, what the prevalence of mask hypertension is 14 to 30%. Mask hypertension means the patient is having normal in a clinic's blood pressure, but all the time, or whenever he is in the his work, his office, in a stressful life, that time every time his BP is higher side. So it's just opposite of white coat hypertension. So in this meta-analysis of 7 studies, what are 2 studies with ABPM and 6 studies with the HBPM. That includes the treatment participant increased CV events and compared mask hypertension to sustained normal. That means all the patients with mask hypertension and those are comparative with the normal hypertension, they are high and grave prognosis for them. So mask hypertensions can be and should be treated very aggressively, and percentage of the all white coat hypertension in general population is 20 to 25%, while the mask hypertension is always 10 to 15%, and incorrect diagnosis because of the physician level or maybe cardiologist level is one. So this slide I want to show everybody very nicely that this dipping should be, this pattern should be always be maintained. This white coat window is what is the window where to see daytime dipping pattern, night window, and morning surge is very important where we can see. So at least the minimum things should be recorded or to see.
Dr. Mandal, I think you have to wrap up within a minute.
Yeah. So another important So I'll not detail. That's only the right final use. Clinical use of ABPMs include a white coat hypertension to be excluded, confirm the diagnosis, and evaluate evidence of in-organ damage. If the patient has any organ damage, then you should go ahead and treat for that. Marks hypertension, diurnal variations, and hypertension. These all should be. And in summary, and challenges are very important. That sometimes patients don't feel to wear this score. And in summary, I'll come to the summary. Evidence shows that out of the clinic blood measure by ABPM or home-based, strongest in the cardiovascular muscularity, and diagnosis of hypertension is by ABPM. It is very important and should be done. Standards of ABPM's report intervention is important, and all the patient to be treated carefully, and the training should be done nicely. And thank you very much. Thank you.